So as efforts to help consumers shop for health care ramp up, it's important to understand whether, as Christoph mentioned, the increasingly popular consumer-directed health plans are encouraging consumers to make value-based decisions about their use of health care services. And to share research on this topic, we're joined by Rachel Reid, an Associate Physician Policy Researcher at RAND Corporation. And I'd like to note that NIHCM Foundation provided grant support for Rachel's research on this topic through our investigator-initiated research grant program, and we're grateful that she's joining us today to discuss this work. Rachel? Rachel, make sure that your phone is off mute, please.
Oh, thank you. Thank you, Catherine. I want to start off by acknowledging my co-investigators, Neeraj Sood and Brendan Rabideau at the University of Southern California, as well as funding from NIHCM, as Catherine already mentioned, and my fellowship, Schaefer Fellowship between RAND and the University of Southern California. So, in the United States healthcare system, as we all know, waste is both common and expensive, with several studies estimating the cumulative annual burden of spending on waste in the range of $750 billion, or about 30% of annual healthcare spending. So eliminating waste is clearly seen as a promising way to save money by eliminating things that add little value to patient health, satisfaction, or well-being. While there are multiple contributors to that cumulative wasteful spending, a substantial proportion is traceable to overtreatment or unnecessary services, or low-value healthcare services. So low-value healthcare services are tests or procedures that offer either no or unclear clinical benefit to patients, but at the same time still expose patients to both risk and expense. And that risk and expense can flow directly from the service itself, or it may flow indirectly through a cascade of additional services and procedures that might be triggered by the initial one. To walk through an example of this, we'll think about imaging for acute low back pain, and I feel like I should caveat myself after David's last talk that I'm a primary care doctor also at a Boston Academic Medical Center. So I do see patients present for acute low back pain. And one of the kind of, an example of a low-value service would be imaging for acute low back pain. Except in a small subset of situations, imaging actually, which means a X-ray, a CT scan, and MRI, rarely alters clinical management or identifies serious conditions. But at the same time, it exposes patients to both radiation and expense. And it may go on to find clinically irrelevant abnormalities that lead to further tests and procedures, referrals to specialists, or invasive procedures that themselves may offer limited benefits or carry risks, such as spinal injections or even some surgeries. Reducing low-value services offers an opportunity to increase quality of care, to increase access to care, while at the same time decreasing wasteful spending and unnecessary utilization. And then accordingly, efforts to try to reduce low-value services have been championed by payers and policymakers. But reducing low-value services first requires identification of them, and one highly visible effort to identify low-value services has been led by providers. The Choosing Wisely campaign was spearheaded by the American Board of Internal Medicine Foundation in 2012 with the release of top 5 lists from 9 specialty societies. These top 5 lists were services within that specialty's purview whose use should be questioned or at least mentioned in conversation between providers and their patients. And since then, the initiative has grown to include recommendations from more than 70 specialty and professional societies. And examples of the type of thing that you might see on one of these top 5 lists are from the American Academy of Family Practice. Don't routinely prescribe antibiotics for mild to moderate sinusitis unless the symptoms have lasted a certain duration or carry a certain clinical pattern. Or from the American College of Obstetrics and Gynecology, don't schedule elective, non-medically indicated inductions of labor or C-sections before 39 weeks. Identifying low-value services can be challenging and fraught, though. Some of these top 5 lists from certain specialty societies have been critiqued for being too cautious, or that they are focused on imaging, lab tests, or medications rather than physician services, or that they focus on things that are not necessarily commonly done. I'm presenting here the American College of Orthopedic Surgeons top 5 list, and if you look at it, it doesn't actually include any physician services there. Professional societies, in turn, cite concerns about making more broad, more daring recommendations for these top 5 lists because they're concerned that the recommendations may be too broadly applied to payment or coverage decisions when there remain instances where a given service might actually be clinically indicated even if it's often low value, or that these recommendations could be marshaled for pay-for-performance or public reporting initiatives. Beyond the challenges of identifying low-value services, measuring and quantifying them presents a challenge, and there are 2 general approaches. Those numbers I presented at the beginning of the slide deck about the cumulative scope and scale of the problem of waste and overuse in the healthcare system, those derive from indirect analyses of waste. These are broad analyses of geographic variation in spending, and they're great for exactly that, getting a general sense of the scope and scale of the issue. But there's a big gap between those numbers and concrete opportunities for change. The other approach is to measure low-value services directly, that is using defined measures of discrete low-value services. And that's helpful because it identifies specific opportunities for improvement. But it can be challenging to undertake on a large scale because many such efforts have relied on medical records data. There's a substantial body of prior research dating back decades that has used medical records to review and assess the appropriateness of tests and procedures. But direct manual review of medical records is incredibly resource-intensive, and accordingly, records-based assessments of the appropriateness of medical care have been limited in size and scope. More recently, some of my colleagues at RAND have looked at the feasibility of using structured electronic health record data to turn some of the choosing wisely recommendations into e-measures. And they actually found some challenges in that the fraction of choosing wisely measures that were readily marshalable into e-records, e-measures from EHRs was relatively small. But measuring low-value services directly using insurance claims provides an opportunity to look at specific concrete examples of clinical care while maintaining a large scope and scale to your analysis. And a new and growing literature is starting to do just that. And this is what we undertook. So we looked at health insurance claims from approximately 1.5 million adult patients from a large national commercial insurer. And we used that data to assess 28 direct measures of low-value healthcare services. These measures represented an array of commonly used services from different types of care, including imaging, laboratory, and other testing and procedures, and then covered a broad range of clinical areas. And the measures derive from a variety of sources, the Choosing Wisely recommendations, U.S. Preventative Service Task Force Level D recommendations, those do not do recommendations, the peer-reviewed literature. And we set out to answer 3 key research questions, and those were, how many patients get low-value services, how much do those services cost, and which patients got more low-value services. On the whole, we found that 7.8% of the patients we assessed, or about 115,000 of our population, received at least one low-value service during the year we looked at, which was 2013. But that the impact on spending was modest, accounting for about 0.5% of their overall spending, or $32.8 million in that population of patients. It's important when you're thinking about that number, though, to keep in mind that we're only looking at 28 low-value services here. And while these services span a broad array of clinical conditions and types of care, they still only represent a narrow slice of all the types of low-value care that's used in the U.S. healthcare system. That said, among the services we assessed, the 3 most commonly received were T3 measurement in hypothyroidism, which is a type of duplicative hormone measurement for that condition, imaging for nonspecific low back pain, and imaging for uncomplicated headache. And all of these occurred in about 1 to 1.5% of patients during the year. And then the 3 services that accounted for the most low-value spending among those services we assessed were spinal injection for low back pain, imaging for uncomplicated headache, and imaging for nonspecific low back pain. And together, these accounted for more than 50% of the low-value spending in our population. We also observed that some key patient groups spent relatively more on low-value healthcare services. White and higher income patients spent relatively more than other groups. And this is important because it could constitute reverse disparities, with more privileged groups getting more wasteful care. We also saw that areas of the country that have relatively higher medical spending in general also have higher amounts of low-value service spending. And this is important because it means our analyses that are directly assessing measures of low-value services mirror the patterns of those indirect analyses that I referenced earlier. We also saw that some groups tend to spend relatively less on low-value services, and this included older and male patients, as well as those who were enrolling in consumer-directed health plans. And we found that CDHP result compelling. So we took a deeper dive to investigate into what's going on. Understanding how patients respond to consumer-directed health plans is important because, as was mentioned earlier, they're growing and have increased more than sixfold over the last decade in the employer-sponsored market. Many enrollees from the individual marketplaces are in these plans, and they continue to feature prominently in Republican plans for healthcare reform. And we already know from existing research that CDHPs appear to save money because patients in them tend to use fewer services. But that work has also shown that when patients cut their healthcare use, they don't spare high-value services like preventive care or chronic disease care, and decrease their use in about the same proportion as their care in general. And this has led to the summary that patients tend to cut both high and low-value care when they enroll in a CDHP. But no one had previously looked at low-value services directly for CDHP enrollees. If CDHPs are making patients into more savvy shoppers, then they should be disproportionately reducing use of these low-value services that otherwise shouldn't be happening at all. So to test that hypothesis, we took advantage of a natural experiment when a group of patients in a traditional insurance plan switched to a CDHP, and we compared them to a group of matched patients who remained in a traditional plan. We looked at the change over time in spending between the two groups of patients. And if CDHPs affect spending either on overall outpatient spending or on low-value service spending, then we'd see a different change over time in spending between the two groups. We ultimately found that patients who switched to CDHPs decreased their overall outpatient spending by an average of about $100 in the year following the switch. But the patients who remained in a traditional plan actually increased their spending over the same period of time. So switching to a CDHP was associated with a significant reduction in overall outpatient spending, and this is consistent with what's been found in prior research. But when we looked specifically at the change in low-value spending over time, both groups reduced their low-value spending a little bit over time. So switching to a CDHP was not associated with a significant change in low-value spending. So consumers are not targeting low-value services in particular to cut. And we parsed the low-value spending into several different categories to see if that pattern was consistent. And we found the same pattern, decreased overall spending, but not low-value spending for laboratory services, in particular, imaging services in particular. And then we looked at services that might be more sensitive to patient preferences, things that the patient might ask for as opposed to things that the clinician is potentially the most prominent driver of. And we didn't find a difference between services that were more or less sensitive to patient preferences. So CDHPs do encourage patients to cut spending, but again, they seem to do it indiscriminately and are not specifically reducing spending on low-value services in particular. To focus specifically on cutting wasteful spending might require different or more nuanced insurance designs with targeted cost sharing for low-value services as compared to high-value ones. Or an understanding of practice patterns so that we can design provider-facing programs to reduce use of those low-value services.